Welcome to the pIBD Digest. This podcast explores paediatric inflammatory bowel disease, including Crohn's disease and ulcerative colitis. We're your hosts, Dr Chris Bakewell and Dr Dr Coelho. In each episode, we'll discuss a specific aspect of paediatric IBD with an expert guest.
This podcast is intended for healthcare professionals involved in the care of children with IBD, as well as for patients and families seeking to better understand the condition. The views expressed are those of the speakers and should not replace professional medical advice.
So, welcome back to the Paediatric IBD Digest. Dr. Coelho, how's it going? Have you settled into the swing of the new year yet?
Namaste, Chris. Yes, settled in totally. It's all good. As you can hear, Bollywood tunes in the background, masala chai in hand. Honestly, what could be better?
Yeah, well, I should say Namaste Tracy, because today we're mixing things up and continuing our journey exploring how IBD is managed in different countries around the world. We've left the brilliant Professor Lissie de Ridder behind in Rotterdam, and we've gone in search of something warmer. And I can only apologise for my pronunciation, but I'm going to give it a go. Aaj kiya India ja rahe hain.
Yes, you're absolutely right. India it is. And by the way, your pronunciation was impressive. Definitely better than my Dutch at the last episode. Our guest today comes from a prestigious medical institute in India, AIIMS, the All India Institute of Medical Sciences, New Delhi. It's where the crème de la crème of Indian medicine end up. So that gives you an idea of the caliber of our guest.
So aside from the air miles, our listeners are probably wondering at this point why we've specifically chosen India for the episode. What's your answer to that one, Tracy? Is this a nod to your heritage, or is there something interesting happening in paediatric IBD in India?
Well, for several reasons really. pIBD wasn't something I came across much during my undergraduate or paediatric training in India. Of course, that was another era entirely, but now the numbers are rising. It's a fascinating and important shift to understand. And yes, subconsciously there will be a nostalgic pull for me there.
No, I'm not lucky enough to have visited India, but my understanding is that there's an interesting mix of genetics, a changing diet, infections and environmental differences happening. And as we know from this series, these are some of the key ingredients driving changes in paediatric IBD patterns.
Exactly, it's a complex and evolving picture, and that's what makes it so important, not just for India, but for how we think about pIBD globally.
And one day someone might actually care enough about this podcast to invite us to India. But for now, let's make do with a virtual tour.
All right, here we go then. So dear listeners, loosen your tie, grab your chai. To India, here we fly. Please welcome Professor Rohan Malik, a GI guru and a super clever IBD guy. Rohan, welcome to the podcast.
Thanks, Tracy. Not a guru, learning the game, as to say. But yes, happy to be here, and I think we'll have a great chat today.
Perfect. Thank you so much for coming. Now, Rohan, we like to get to know our guests, so I wonder if, straight off the top, we could ask you to maybe introduce yourself to the listeners a bit.
Yeah, sure. So my name is Rohan Malik. I'm a pediatric gastroenterologist. I run a GI unit for children at a large public hospital in New Delhi. The name of the hospital is the All India Institute of Medical Sciences. And it's a busy unit. It's a small unit compared to if you see the number of consultants, residents, etc. But it's a busy unit. And I have been running that unit since September of 2015. You might be surprised, I'm the only consultant in the unit. And although we are hoping we will get some more in due course of time. And I finished my training predominantly in India in 2015. And at that time, there were no formal training programs for PGI in India. The first one was started at another large public hospital in Lucknow, which is another city in the north of India. And me and a colleague of mine, we were the first sort of trainees that graduated the structured program. And then I did a year at the Royal Children's Hospital in Melbourne, uh, planning to do a career in hepatology to start off with. And then when I went home, this was the first job I got, and was asked to sort of, there was rudiments of a unit there with there had been consultant who had sort of finished up. So there were some elements there, and so we set it all up. And the way things stacked up was we couldn't get the liver program going because we didn't have a surgeon to operate on the kids in the hospital. And we saw more and more inflammatory bowel disease as time went on. So that sort of became one of the sort of focuses of my work, I would say.
Great. So, Rohan, I know you're on a sabbatical now, but primarily, as you have just said, your home IBD unit is AIIMS New Delhi. And we were just discussing, now clearly only the best of the best make it through those doors. So well done. And I know you mentioned how you ended up in the IBD specialty, but was there something specific that really hooked you to it?
Yeah, it's a good question. I think as gastroenterologists, we all come back to the fact that the basis of all disease that we treat is in some form starts in GI immunology. And IBD is such a fascinating field when we think about it, because you won't believe, when I first started my job as a young consultant, I had a child with Crohn's and a stricture. And this is like in the first 2 months. And I went up to the head of pediatric surgery and said, this child needs a resection. And I was laughed out of the room that we don't see Crohn's in this country. And then they resected him and he had Crohn's. So, and this is not a child who is on a, standard American diet or a westernized Northern European diet. This is a child from a sort of average Indian family in a rural setting. So why does he get inflammatory bowel disease? What triggers inflammatory bowel disease in this setting, not the classical setting that you always sort of read about and learned about? The other thing was we didn't see a lot of IBD when I was training, but we see a lot of IBD subsequently and now. So it was something we read about and then saw and learned as we went along, I'll admit. So our IBD skills at the outset were not the same as your IBD skills or someone training in North America or Europe. We had to learn on the job sort of, because you have to look after these patients. The other thing when you work in a country like India is it's very challenging in terms of resources, medication, the finances, the infrastructure. It's all there, but to put it together can be difficult. And when you're a physician, I've worked in both settings, in Australia and in India. When you work as a physician here, you are a physician, but in India, you have to be the social worker, you have to be the advocate for the child, you have to be an administrator. And as I said, I initially started out thinking I could start liver transplants in the public sector, but since that didn't happen, I found I could make myself useful looking after this increasingly growing cohort of children which require ongoing care. And it was a funny story. One of my friends had a coronary event very early in life, and he's in the stock market in Bombay, so obviously he's very well off. And so after he recovered, sort of born again, he said, "Oh, I want to give some money for kids. Can I donate to kids who are undergoing transplants?" So I sat down and did the maths with him that you will give a certain amount of money for one surgery, whereas if you calculate how much resources are required for a child with IBD who's going to live with the disease for the next foreseeable future, that's a much bigger job to do. So I think it was a combination of scientific curiosity of why IBD happens and how to help these children get better chance. That was what was in front of me at the time, and opportunity that the huge number of the large opportunity I was given working in a busy public hospital. So I think sort of the perfect storm, really.
Sadly, I and Chris do not have any friends in the stock market, but here we go.
Yeah. So you've touched on a really important point and something that we'd like to pick up about this incidence of IBD. And throughout this series of podcasts that we've been running, we've been fascinated about what's happening with IBD around the world, because of course, in many places, there is an increasing prevalence. So from your perspective and your kind of patient cohort, what is the current prevalence of IBD, pediatric IBD in India? And do you get a sense of perhaps why we're seeing rates rise even in that part of the world?
Chris, I can't tell you the exact prevalence because there are no epidemiological studies or population-wise studies of inflammatory bowel disease in India. In fact, we recently wrote a paper which is accepted, which diagnosis of pediatric IBD in the Asia Pacific. And Asia Pacific, as you know, is a very diverse group of countries. So we don't know what is the exact prevalence. It's obviously not as high as Northern Europe. What I can tell you is that it is increasing, and it is increasing along with the fact that we have a huge population, 1.4 billion. So if you say, I think Northern Europe is, I correct me if I'm wrong, it's about 1 to 2%, 1% maybe, inflammatory bowel disease, somewhere between that. So even if it's 1/10 of that, that's a lot of people with IBD. Some work done by my senior colleagues in the adult unit at the All India Institute projects that if you look at the total number of IBD patients in the world after the US, India is set to be number two, or set to be number 2 soon. And I'm sure we'll touch upon it later, is that we still have a lot of TB. So it makes a very challenging and unique situation. So I would say, in summary, it is increasing. For example, when I was a trainee more than a decade ago, we would all the trainees would come together when we admitted a child of IBD, because we hadn't seen one for weeks. And now in an average clinic, we might get 2 or 3 new cases of IBD. So it's, I mean, by word of mouth, I can say that it is increasing a lot. And also there is a lot of interest in IBD in the region, South Asia, as to why we have more IBD now. And I can't answer that question. But I think we will know. There's people who are much smarter than me, who spend a lot more time on research than me, who will tell you that answer.
Rohan, it's not surprising that globally we are consumed by this rising incidence of pediatric IBD. And as you mentioned during your training, IBD was very rare in your clinics, but not anymore. And if I share my own experience of training in Goa, Mumbai, a couple of decades ago, I don't recall seeing any case of pediatric IBD. Yes, I understand the difficulties in knowing the precise prevalence or incidence in India, but do you think it is very metrocentric or not really?
Tracy, I can tell you, I work in a public hospital, and the children who come to me are not from the metro. They are from rural and the peripheries of the urban areas. I have gotten patients with IBD from small villages in the heartland of rural India. So it's not. It is not a disease of affluent middle class Indians only. For example, portal vein thrombosis is something we see only in children who are from a lower socioeconomic background. But inflammatory bowel disease, I think, affects all children of all classes of in India, those who are from whose quality of life is similar to living in Europe, in the big bustling metro cities of India, and children from the rural hinterland also. So it affects all of them, which I can't explain why.
No. And of course, we know from lots of research that there are genetic, environmental factors, diet, all play a really important role in pediatric IBD pathogenesis. I was wondering if you could give us an insight specifically about those things in India. Do you think there's anything unique about the pediatric IBD population and the kind of environmental or dietary or genetic pressures that those children are undergoing?
It's a big question, Chris. I mean, look, there's few things that I can tell you from my whatever experience I have. There is a very India has industrialized in the last 50 years or so, and the penetration of processed food and diet and all these modern habits of modern living has penetrated everywhere, even in smaller rural settings. So, packaged foods and processed foods and all of that is there, but obviously not to the extent that you would expect it to cause a big shift. So I can't blame it on diet alone. Environment is an interesting one, because I don't know whether there's something in our environment, the way we handle our industries, or all of that, if that is something, but that is so nebulous, and I really have no great knowledge of that sort of area, but that is something that is possibly that can be explored. The kind of disease, like in the West, when you talk about family history of IBD, most of our children don't have family history of IBD. Nobody's been diagnosed for IBD ever here, so they usually don't have a family history of IBD. And the Crohn's, so the north of the country, for some reason, sees more ulcerative colitis, and the south sees more Crohn's disease. And I think in Japan also they have this sort of a UC predominant phenotype. I'm not sure why they have that in Japan, but in India, although Crohn's is more common, if you look at this the large multi-center series we published in 2020 from the north and the south, although Crohn's was around 60%, UC was, the proportion of UC was more in North India than in the south. TB is more common in the north and less common in the south. So it's sort of, it has got a reciprocal relationship with the incidence of Crohn's. So maybe there is something to that. The phenotype of Crohn's that I have seen in North India, Delhi is a city in North India, our colleagues in the south are great clinicians, and their patients never come to us. So I have not seen sort of severe penetrating perennial Crohn's that I have seen in Australia, for example. I wouldn't say it doesn't happen. Of course, happens, and the adult units have a lot of complex perennial disease, but I have not seen a lot in children.
Yeah, really so interesting. So whilst we are on this topic of contributory factors, so in the West, Europe and North America, there's a rising incidence of very early onset IBD, that is less than 6 years of age, and infantile IBD, less than 2 years of age. And it is often hypothesized that perhaps it is more to do with genetics. So the younger the patients, more likely to harbor nasty deleterious mutations compared to the more polygenic forms of IBD in later life. Now, in your practice in India, have you been seeing a similar sort of a trend in younger patients? And as you have alluded to, there is no clarity yet if it is the environment, diet, genetics. What are your thoughts?
So this is a very interesting question, Tracy, and thanks for asking it. So I had the same thought maybe 5 years ago, and then we asked for some funding from the Indian Council of Medical Research. We were following, what they published from sick kids, like the 1,000 genome study. So the plan was to do whole exomes whole exomes of all IBD patients at all ages to see, what proportion of this is genetic. Of course, that just picks up genetics. You don't look at epigenetics, but that is where I started the first sort of fund from. So we got some funding. We looked at a few cases, and then we got some. We were part of, along with other centers, we were part of a Wellcome Trust grant with some translational scientists from Bangalore who were looking for specific mutations. But as part of that study, we looked at pan-India, North and South mutations. I initially started looking at all patients. And, as your funding starts to dry out and you don't have those mutations, you start hunting for mutations. You start looking at younger patients. But a couple of things from those two studies, both are still ongoing. One is almost completed. The second will run for a few years. Two things is, one, we see the same sort of genetics, the classical very early onset IBD genes that have been reported from North America, Europe. So, IL-10, CGD, CAP. We have all of those mutations. We have all the other rarer mutations as well. And it follows the pattern that is well described in world literature, that the younger the patient and, all those things that you look for very early onset. The only thing that was a bit novel in those cohorts of patients was we had this particular phenotype that was, we initially diagnosed as small bowel Crohn's, ulcerating clones only in the small bowel, presenting with anemia, protein losing enteropathy, and circumferential ulcers with some strictures in the small bowel, picked up on capsule, sort of resistant to therapy. And then in this cohort of patients I had a few siblings, two pairs of siblings actually, that had the same disease, two boys and pair of boy and girl. And I said, oh, I've got some funding. This looks funny. Let's do some genetics. And we did genetics for them. And it came back as SLCO2A1 mutations, which govern the prostaglandin synthesis. And at that time, I thought, oh, this is amazing. This is a big discovery. I'm going to be a famous man. But I looked into literature, and it's well reported in Asia. It's well reported in Japan. It's well reported in Korea. There's reports from China. A lot of work in Japan. And this is, if you remember, you're a senior gastroenterologist, you remember something called chronic multifocal sclerosing ulcerative CMUs, chronic multifocal ulcerostenosing enteritis. It was like a waste paper diagnosis where you had multiple ulcers in the small bowel, which we didn't know how to treat. And this is called CNSU in the East and CMUSE in the West. And now they've reported the same thing in Caucasians from France. And if you look at that table, I think in Bolton's paper, where they go down all the mutations, SLCO2A1 is one of the monogenic mutations that is in the table of, monogenic IBD, but they present later. So that was the only sort of region-specific genetic diagnosis that I got on that cohort of patients, which you will not find in a usual European or North American cohort. The rest were in keeping with what we already know with genetic forms of IBD.
Sure. And then I guess thinking about how you treat these patients, if you're getting more and more pediatric IBD, can you give us a sense of your standard treatment protocols for IBD? Do you think they differ at all from Western or North American populations? And I guess on that point, how accessible are these new biological treatments for your children?
So, Chris, the how we start depends a lot on funding. So, if a colleague of mine who's working in Bangalore, seeing a patient who's coming, whose parents work in IT, is diagnosed with Crohn's colitis, they'll get started on EEN because you have to pay for your EEN. And 6 to 8 weeks of EEN will cost you about £500 or so, which is an exorbitant amount of money for a lot of Indians, unfortunately. Not not all Indians. There'll be like 200 million Indians who can afford that easily, but the majority of the billion that are left over can't. So for them, this discussion around induction becomes moot because the prednisolone tablet is the only accessible therapy to start off with. So it depends what, and what system you're on, because there is no unified NHS like system in India. There is a system which is split between state, federal, and private. So it also depends on how well the system supports you. Then it will usually be, induction followed by maintenance with the immunomodulator. And we would usually not go unless, there is a fistula or a stricture, and not go strong with biologicals straight off. But I think that varies between Europe, Australia, and North America as well. So that's not something unique to us. But we would generally try immunomodulators. So the question really is how easily or accessible are biologicals. Infliximab, or especially now with generic infliximab and generic adalimumab, I would say now in the last 4 or 5 years have become very accessible. In addition, there is a federal scheme called the Ayushman Bharat scheme, which will pay for these if you come into hospital to have the infusion in daycare or something. So they will pay for. But you have to go to a public sector hospital. If you go private, then you have to pay for it yourself. Even access to Stelara, if you push, you will get access to Stelara. And Vido. So we have access to all of that, but it's not like you guys have to, in Europe or Australia, you have to fill out a form, and in Australia, PBS or NHS gives you, there's no sort of, you satisfy the criteria, you fill out a few forms. Of course, you have to wait a few weeks, you get the medication. But here it's a little bit harder because they're expensive. But if you go to a good public sector tertiary hospital, you will get them. The other game-changing thing is now, I think, small molecules. And we had a little bit of experience with tofacitinib, and now UPA is available in India finally. And for tofa with UC, I think if you look at the algorithm, the European Society algorithm, tofa, I think, comes after you've exhausted your biological, or at least your first biological. If there's no, if you're not doing well, you might think of a small molecule. But here, I think it would come earlier. It would be sort of an equivalent medication to a biological. Because it's cheaper. Tofa is cheap, not UPA. UPA is still not as expensive as in Europe. But the other thing is accessibility. It's a pill that you can pop, and so I think in terms of the drugs, you would have small molecules to sort of on the same shelf as your biological, just because of ease of use and cost. You can get all the biologicals now, and if you can't afford them, you can always go to a public hospital and you'll get them. So I think that has changed for sure.
It's really interesting. I wonder if someone has had the idea of writing up as a case series or as a study the concept of going straight to these small molecules from, not necessarily from diagnosis, but early on, because we use it in the West and in Australia as a kind of rescue therapy or last line therapy. Your experience then is going to be quite different, and it will be really interesting to see how patients fare having small molecules early on. I'd be interested to see that.
Yeah, so I think I started a multi-center sort of collection of kids on tofa about 2 years ago, but I have a lot of inertia in my system, and that thing didn't get off. But the center at Lucknow has just restarted just collecting data. So it'll be interesting from a national point of view. Also, I think the UPA trial, which I think has just finished or is finishing, they let you use UPA on par with, even if you're biologically naive. I might be wrong, but I think in Asia and in Australia also, they let you use it if you're biologically naive. So I think what will happen now is um, with all of this data, we might be better placed to talk of UPA uh, and whatever else is going to come down the line as sort of on equivalence with biologicals, I would expect, especially in South Asia, in the Indian setting. I think it will become the go-to drug.
Thank you. That's very interesting. So, Rohan, from my experience working in India, of course, several light years ago, and as you have just mentioned, the diversity in healthcare setups from government to private hospitals, people who can afford, people who can't. Now, there are bound to be challenges in diagnosis as well. And if I tread carefully, even the possibility of misdiagnosis in certain under-resourced settings. So, do you want to share your perspectives on that?
So yes, I think that's a very valid sort of concern. The adult world is a bit lucky because there are a lot of really good adult gastroenterologists in India. Indian gastroenterologists are well trained, and they talk a lot about IBD in their national meetings, regional meetings. And an adult gastroenterologist is more of a community-based person. Each community has so many adult GI patients that they will have an adult gastroenterologist somewhere in that community. So often the adults get diagnosed with TB or IBD. Children, I think the pediatricians are a little bit behind the curve in thinking of IBD in the differential diagnosis of children. So often tuberculosis is thought of as, if you have someone who's not growing well and is having abdominal pain, fevers, TB is often thought of, and then they're treated with almost, I think every patient I've seen with Crohn's has been treated as TB. I don't think I've ever seen a patient with Crohn's who wasn't treated as TB, just because they've been through several layers before they come to us. So I think we are a little bit behind the curve, but that is changing because people are talking about IBD in meetings, and they're asking gastroenterologists to come and speak about IBD, and it is becoming more prevalent. So it is changing, but yes, I'm sure that there are cases that they don't think of IBD in the differential, and I think that will change slowly. And as India is diverse, depends on where you are, that will make a lot of difference as well.
And whilst you're on the topic of TB, as we all know, TB is so prevalent. With the use of anti-TNF alpha agents, that adds another layer of complexity because of the reactivation of latent TB when you start anti-TNF alpha agents. Now, could you share your perspective on how these issues play out in the real world clinical practice in India?
Yeah, sure. So there's a couple of things that we have to think of. One is Crohn's and TB look almost exactly the same. Endoscopically, radiologically, they're almost exactly the same. So often we're not sure whether we're dealing with Crohn's or TB. So we would often treat them for TB for 3 months, 3 to 6 months. And if there is clinical improvement after 3 months, you keep going and you rescope, because if it is TB, there will be mucosal healing. Crohn's symptomatically gets better on therapy for TB, by the way. If you give them the antibiotics you use to treat TB, there is symptomatic improvement in 30 to 40% of patients with Crohn's. So that's why you have to rescope them to make sure that this really is TB, not Crohn's. So you can try to do bacteriological isolation and all of that, but often you end up having a therapeutic trial and reassessment scope. So that is one problem with TB. The second problem is when you're starting biologicals, when there is activation of latent TB. So often you will have an IGRA, you will have a CT chest, and to assess for latent TB, and you have to put them on some therapy for latent TB when you go to biologicals. And then we've had a few cases who have reactivated, and then you sort of have to balance, generally you have to stop the anti-TNF and start them on therapy, and then maybe go to an immunomodulator, or you have to divert a few. So depending on the case, then you play around with the factors that you can play around with, and take it from there. But these two are the real life scenarios with differentiating diagnosis of Crohn's versus TB versus reactivation of latent TB.
And of course, clinically, it can be very challenging to differentiate between an IBD flare versus a TB flare or reactivation?
Yeah, it can be difficult. And often when you start treating TB, there is something called immune reconstitution syndrome that can cause sort of a flare. So then it can get complicated. Um, uh, and we often ask our colleagues from infectious disease or TB specialists to have a look in, suss out, but it can be difficult.
Now, you mentioned you have an enormous population, over 1 billion people in your country. And from what you've said, it's not necessarily just the children in the big cities that are getting this IBD. Lots of people in the regions, maybe very remote areas, who travel a long way to come and see you, potentially, I'm guessing. Can you give us an insight? What are the challenges in the long-term management of what is a chronic, potentially lifelong condition? How do you maintain adherence for these patients, monitor their treatment, and make sure they're coming to their follow-up appointments?
I think one thing I will say about the Indian psyche is adherence is not a problem for our adolescents. I think you tell them to take their drugs, they take their drugs.
Yeah, we could learn a lot from that, I think. Yeah.
I think it's cultural. I'm sure Tracy would agree, but adherence is generally not a problem. I mean, small percentage, of course, will have. The problem really comes in the other aspect of our Indian psyche is that we want an end to the therapy. All patients, their first question is, especially if you start tablet or a biological, that, okay, you're starting this, how long do I have to take this therapy? They really want to stop it. That is the first question they ask when you start it. So that becomes a problem. And there are studies to show that some of my adult colleagues have done studies that if you give them biologicals for a set period of time, 2 years, and then go to an immunomodulator, that has, and you're able to maintain remission, that has some economic benefit. And often different from the adult world is the pediatric specialists are very centralized in big cities. So, and telehealth, in a public hospital, telehealth in India is not possible in a public hospital in pediatrics. It's because the numbers are just too great. You cannot have telehealth on those numbers. My clinic will have about 80 patients in one morning, so I can't do telehealth on top of that. So, it's not logistically feasible in the public sector. So, although it would be ideal, but it's not feasible. So, follow up after a certain time. After a certain time, we develop sort of informal mechanisms of follow up. They have the phone numbers of the nurses on the ward, and they will call up and check in with the IBD nurse with what's happening, and try to do telehealth in an unofficial sort of way. Because as I said earlier, it's not, your role is not defined as just a physician. You'll have to do so much more. So because it's IBD, not everyone sees IBD. You make these sort of mechanisms so that they can do some sort of remote follow up. A few of them do stop turning up for follow up because of distance and time. A lot of them, once they start getting better, they stop their medications and then come back with relapses or needing surgery. So I think that is the real challenge. The diagnosis we are getting better at. Accessibility to therapy is also there. I think just follow up and supporting them throughout this whole IBD journey, especially in terms of nutrition, that I think is a major challenge going forward.
So, Rohan, you mentioned about the funding schemes in a government setup. Now, obviously, these medications, including biologics, need a sustained treatment. Is there a sustained funding available for people who need all these medications?
So, Tracy, like I said, there is, as you know, there is a disparate sort of health system. There is a national federal insurance that is available to all families of a certain income. So it's not available to all Indians. It's available to all families at a certain income scale. Bear in mind, these incomes relative to pounds, going from one income scale to another income scale is not a big jump in terms of absolute money. So you could make a little bit more and be out of this scheme, So, so that there is that scheme which is been, I would say, fairly good because it has given us access. And then there are health systems. For example, the hospital I work in is a health system onto itself because it's a very big hospital. So the hospital will fund biologicals if you come to the hospital. The state that the hospital is in, although it's a federal hospital, the state that the hospital is in, that state has its own health system, and that state in, for example, Delhi, will fund biologicals for anyone who lives in that state. So if you are in a state like that, then you have access to biologicals. If you're in a state that doesn't do that, or in a hospital that doesn't have the funding, then you're you're on your own. You have to fund it out of your pocket. There's lots of activism and fundraising. A lot of people who are very passionate about treating inflammatory bowel disease who do help, but it can often be a struggle. I will be honest with you. It can often be a struggle. Starting biologicals, sustaining biologicals is a struggle. We now also have levels which we do regularly. So all of that's coming in, but it comes down to cost, and it's a very cost sensitive region, and there is no way that people can fund this themselves. So it has to come from the system, which it doesn't completely at the moment.
Yeah. As I mentioned before, in my days in India, pIBD was an extremely rare diagnosis, or something which I never saw. With the rising incidence, is there sufficient awareness among pIBD among general pediatricians, you think, and other healthcare professionals? And from this podcast, do you have any message for pediatricians, particularly in India, who may be listening to this podcast?
Tracy, as you know, India is very big and diverse. Like if you are a pediatrician and living in the south of Delhi, you know IBD very well. You will refer as soon as you suspect. If you're working in a rural setting in Uttar Pradesh or Bihar, you will never think about it. So I think as the country becomes more prosperous, and we do more and more teaching in terms of our pediatric conferences and talking about IBD, just putting the word out there. So I think they will think. I would really urge all pediatricians to think about IBD as a differential. The simple rule of thumb is, of course, when you have UC, you have blood in the stool, that's very easy. You have to go to a gastroenterologist. But when you think of TB, I think of Crohn's as well. So if you have a child who you're treating for TB is not getting better, you should think of Crohn's. That's really my message. Think about it. There's always a large city in your area which will have a pediatric GI, or use your adult GI colleagues. They're very useful in the community. They're very happy to look after older children. Use them to do the scopes, make a diagnosis, but think of IBD and educate the pediatric fraternity on IBD.
And how do you see pediatric IBD, sort of the landscape of the disease and the treatment changing in India, maybe over the next 10 years? Is there anything that you want to see focused on? Anything that you think will be important, maybe research gaps to be filled?
I think there's a couple of things that will, I think, make a difference. One is we need to come up, the pediatric research community, the pediatric IBD research community in India has to do more prospective multi-center work. We have to collaborate among the large centers and answer questions which give you practical guidelines for the region, not answer questions that will give you a good talk in Isfahan or nice paper in the European Journal of Gastroenterology, but answer questions that will not be very glamorous, will not have traction outside India, but will be really important to treat the cohort of patients that we do have. For example, is TOFA or UPA as good to start straight off the bat if you need an immunomodulator, or if TOFA and UPA, when is TOFA as good as UPA in our setting? and how do you monitor these, and will shorter courses of biologicals be as good as sustained biologicals? It has to be tailored to the reality of this, large, diverse, absolutely huge population. And there are perhaps no great prizes there in terms of the world stage, but I think we have to bring up the IBD research in a more practical, pragmatic way so that we have some real world answers for the region rather than, I think, in some way pandering to European and North American perspectives of IBD and putting our flag on the table that yes, we also see IBD and we have something to say. I think that's sort of a slightly pessimistic view, I would say, but that's what I think.
No, a call to arms for pediatric gastroenterologists in India, hey? Translational medicine in the next 10 years.
Yeah. So, Rohan, I think we are at the end of our scientific session. It's been great. I have learned a lot. But before our listeners get to the stage of podcast fatigue, I've got a poem to share. I know you haven't really slaughtered the food chain giants, which I might do in this poem, but anyway. So, my full disclaimer, this is not peer-reviewed, so I would urge our listeners, please do not dissect the science too deeply. It's really just a light-hearted mix of nostalgia, mild rebellion against the fast food chains, and perhaps even a small defense of those not so hygienic but utterly delicious street foods that we all secretly love. So the title of the poem is The Street Food Hypothesis. Savoring the bygone days through my nostalgic lens, the blaring horns of vehicles always so intense, metered tuk-tuks defying precarious bends, momentum that makes no logical sense, and of course the sumptuous roadside indulgence sizzling in uncelebrated humble pans, the delights of the tastiest foods of money's worth, not in pounds but in pence. Surely the traditional hygiene buffs will scoff through their legit claims, salmonella, shigella and other microbial dames, vengefully playing their usual tropical games. But in the insalubrious mix of these nasty games, could there be a friendly bunch, as the hygiene hypothesis often unshames? Those protective sentinels of the immune frames, shielding the bowel from the wrath of chronic flames. Mind you, there's a bigger culprit lurking here, advancing countries that in the decades past seldom saw inflammatory disease so near. But now look around, the infamous fast food giants dotted across the sphere. This is all what research says, not my tone in a demonizing gear. Apologies, folks, should these verses evoke needless confusion and fear. Thank you.
It's very, very nice, Tracy. Thank you.
Thank you.
We can say goodbye to the fast food sponsorship, I think. Look, Rohan, I think this has been a really productive talk. Thank you so much for taking the time to come and speak with us and for educating our guests about India, pediatric IBD and all of those things. Hopefully we talk to you again in the near future, and we hope that the next decade really does lead to a big change in sort of transitional medicine in the treatment of India, specifically in pediatric IBD. And I'm really looking forward to hearing more about it.
My pleasure.
Take care. Thanks.
Dear listeners, we hope you enjoyed joining us on this tour of the pIBD landscape in India. Until we meet again at our next destination, goodbye for now.